Hello and welcome to the latest episode of Lovegrove on Health. My name is Dominic Lukes, Product Marketing Manager at Skills for Health, and joining me is Andrew Lovegrove, Skills for Health Senior Consultant. How are you, Andrew?
Hi there, Dom. Great to be back with you. We're really getting into the swing of these podcasts now. So I'm well, just recently back from holiday, so nice and relaxed, and it feels you go away for a few days and the whole world's changed. So I'm sure we'll have lots to talk about today.
Yeah, it's great to be here again to get your views and insights on the latest sector news and workforce development issues. And the feedback about the podcast have been really positive today. And it's great that so many are working on the health sector, are subscribing and finding them relevant and informative.
Absolutely. I will admit, when we first started doing this, will it just be me and you talking in an echo chamber? But I am aware that people are listening to us. And it was really nice the other day. A former colleague of mine got in touch just to say that they'd found the podcast, they'd listened to it, and they really enjoyed it. They said I was a natural, so I'll try not to let the congratulations go to my head. But it's nice to know that people are actually listening to us.
Yeah, that's fantastic. I also got an email last week to say we were the 55th most downloaded podcast in the medicine category in Apple. They didn't tell us how many podcasts are in Apple. So like you said, if there's 56, it's not too congratulatory, but we'll take that anyway.
I'm a great believer. We take the wins wherever we can find them.
Absolutely. So we've selected quite a few news stories this week. So the chances are this is likely to be one of our special news edition Lovegrove on Health podcasts. But I think that's what's so great with this format. We can keep it flexible, highly topical, and react to what the sector has given us to talk about. So perhaps enough for the build-up. I guess we should probably lead with the publication of the government's Living with COVID plan and the ending of restrictions. I know you've spoken about this issue on previous podcasts, but just want to get your thoughts on that Living with COVID plan.
Well, it's happened. You know, the decision has been made. We are now living with COVID, quote unquote, and the restrictions have ended. Obviously, in England and other UK countries have signalled a move out of COVID restrictions over the course of the next couple of weeks. So it really does feel now that we're moving into that next phase. I nearly said the new normal then, which is an expression that I have mixed feelings about. But anyway, we're moving into the next phase, and we will wait and see what happens. Obviously, the Omicron wave has not been as disastrous in terms of mortality levels as we perhaps thought they might have been. But, you know, the number of cases is still higher than I think we would like it to be. And, you know, we are still recording people dying within 28 days of a positive COVID test. So for me, there's that balance of readjusting, but not thinking, you know, the all clear has been sounded either, because I think living with COVID means just that. It's something that's present and we have to adapt our circumstances to that. I think one of the things I worry about the most is people, potentially those who have employers who are not altogether sympathetic about sickness, is that people now, if they only receive statutory sick pay, will have to go 3 days before they can claim. And for a lot of people, going without 3 days pay is not an issue. So even though the advice is, if you test positive for COVID, don't enter the workplace, if you have an employer who's following the very strict letter of the rules, what dilemma does that actually put individuals in? So I worry about that. I worry about people who will attend work through sheer necessity, but that then puts themselves and their colleagues in harm's way. So a little bit worried about how that will unfold. But I guess we are moving into better weather. We're in March now. The daffodils are out. So as better weather comes, infectious diseases sometimes aren't quite so concerning as they are during the winter months. But I think for me, it's a wait and see. We may still have to readapt things that we haven't thought about so far. So living with COVID, yes, it's happened. We've transitioned, but I really don't want people to think that COVID is over.
No, and I suppose one of the worries has to be further mutations of the virus as well. And I suppose once people are sort of relaxed and not got used to, the previous restrictions that were in place, how easy it would be to change people's behaviour.
Yeah, I mean, I think Omicron, because it was, I mean, I'm not an epidemiologist, so I'm probably going to get told off for what I'm about to say, but it feels in layman's terms to have been a milder variant than the two that preceded it. Certainly in terms of the mortality statistics, it's not been as disastrous as the previous variants. So is that lulling us into a sense of security that if there are future variants, will they be more Omicron type variants? So therefore, it becomes a game of, not a game as such, but you know what I mean. It becomes a round of diminishing returns, and it becomes more of it's just another virus. But let's not forget, we do have thousands of people every year who die from flu, and flu is, another virus. So we need not to think that it's just something that's there and let's pretend it doesn't exist. We've got to live with it, and living with it may still mean adapting some behaviours. Personally, when I'm in crowded spaces, I still wear a mask. I know others don't, and I'm not going to sit here and lecture people on the virtues of mask wearing, but it is my personal choice, and my personal choice is to wear a mask because I feel that's me contributing to maintaining a safer place in communal areas.
Mm. Yeah, I was on the bus yesterday in Bristol, and it's probably about 50-50 people wearing masks and people not wearing masks. But I was also reading last night in the US, there's still 2,000 deaths a day with COVID over in the States. So it said it's just different pictures across the world, isn't it, at the moment?
And as with flu, it moves across the globe with almost with the time zones. So Australia, New Zealand, they're about to enter their winter period where they're all going to be. I mean, Australia doesn't have our winters, but you know they're entering that period of the year where things like seasonal flu start to spike. And what Australia has during March, April, May, June, we then tend to get in November, December, January. So I think our public health colleagues and our health protection colleagues are still going to be keeping a sharp eye out on variants and what's happening with sort of viruses more broadly for the next number of months. I hope we are moving away from the darkest of dark days, but I don't think we're quite at dawn light either. It feels the sun might just be on the horizon, but it's not fully exposed in the sky.
Yeah, it's probably still going to be a topic that we talk about in future podcasts, isn't it?
I think we will return to kind of COVID recovery on many occasions for the next several podcasts. But equally, we're aware there's lots of other things happening in the world and things happening within health and healthcare that equally deserve some airtime.
Yeah, and perfect cue. So one of the other news stories that kind of caught my eye, certainly in the last week or so, was the virtual care wards. It'd just be interesting to get your thoughts on how you see virtual care wards being a major part of healthcare service going forward.
I'm at risk of playing cliche bingo now, but somebody once said to me that necessity is the mother of all innovation and invention. And virtual wards are not a brand new concept, but they've certainly come into their own and have become a much more topical item in response to COVID, because we needed to care for people in a non-hospital environment in a way that we traditionally have not done so. And the idea is that that's something that we want to continue and not just be seen as a COVID time solution. So it kind of goes back to, what are the lessons learnt from COVID, and what are some of the best things that we can take from our COVID journey from the last 2 years that we would want to continue, perhaps make more mainstream. And the virtual wards, I think, are one of those examples. I know the idea of sort of having virtual care wards moving forward, becoming more mainstream, is not without its detractors. I've seen a couple of people have come out and expressed concerns around patient safety, thinking about governance, thinking about what the workforce needs are in order to make this happen, and also that it's not a silver bullet to dealing with some of our capacity issues across the health system. And I would agree that virtual wards are not a silver bullet. That is not the answer to dealing with patients bed blocking, ambulances not being able to offload the patients. It's not the answer, but I think it's part of a response. And it's, for me, it's about the care being in the right place at the right time. And I think there are a cohort of patients who can be looked after in a non-hospital environment and can be looked after very safely and very effectively.
I guess virtual wards, they've certainly gained traction during the pandemic. And do you think that traction's been supported by the fact that people are more confident about receiving remote care?
I think there are a great number of people who would prefer to receive care in a if I call it a non-hospital environment. I remember my dear old grandfather was terrified of hospitals. He said, "Why would I want to go there? They're full of sick people." And, sort of as a family, we might sort of had a little giggle about that. But there are occasions where being in hospital is absolutely the right place for people and individuals. But there are a number of occasions where it's absolutely not the right place to be. And for me, we've got to think about how we configure our services to meet the needs of patients, and that we provide that care in the best possible place for patients, for individuals, and not just at the convenience of some of the structural things we have in place. So, we think of hospitals as buildings. It's almost a noun and an adjective, but actually we can provide some of that care that we've traditionally provided in hospitals in virtual environments, supported by community teams, in order to best meet patients' needs, and actually in an environment that better suits them. Generally speaking, I would prefer to be looked after and receive input in my own home, not in hospital. I recognise there are times where I absolutely would need to be in a hospital environment, but I don't always think it should be seen as the default for everything. And I think COVID has perhaps expedited some of the thinking. I appreciate people's natural concerns and worries about it, that we need to do it in a thoughtful, structured way. And going back to something I think I said in a previous podcast, we have to think about the whole health and social care system. So virtual wards, responding to patient needs, we can't just draw a circle around it. We need to think how it interfaces with other services, but how we structure it, and some of those other services in a more holistic way, so that we wrap our care and interventions around the needs of our patients and not around our organisational boundaries.
Mm. Do you think the sort of push for virtual care wards, is that driven by economics, do you think, or is there other factors in play here?
So I think I would be naive to say that economics are not a factor in this. I don't believe they're the only factor in this. I remember a colleague many years ago who used to say that, in of itself, a hospital bed minus any actual treatment is probably the most expensive hotel anywhere in the local area. So actually, people being in their own beds is going to have a cost benefit potentially. Of course, that's only a benefit if that's the right place for them to be, and we can provide the care in a different way. I think historically we have that very paternalistic view of healthcare, and I think virtual wards are an example of perhaps moving away from that. That actually the power sits with patients, families, carers, communities, and it's not exclusively in the hands of health professionals and the structural physical environment that we operate in. I think COVID has probably expedited that. I remember somebody saying to me that if we hadn't have had the space race, we wouldn't be using Teflon frying pans. When our backs are against the wall, we create, we innovate, we come up with new ideas, we try things, and we're probably a few years ahead of where we would likely to have been had COVID not happened. So I think the way the policy is communicated needs very careful handling, because I think people will see it as, oh, this is care on the cheap, or this is care being done in a cheaper way because we haven't got the money. I actually look at the world more glass half full. I think there's a real potential to actually improve health outcomes for people, but that will be in large part down to having a safe, skilled, capable workforce actually providing that care, and they have the knowledge, skills, behaviours able to do that, and the leadership of health and care systems actually work together collaboratively to support it. Because without both of those things in place, then I would suggest it's on a very rocky road. But there are examples of where it has worked. It's worked well. There are lessons to be learned. We need to reflect on those lessons to embed moving forward. But there are a couple of things that we absolutely need to have in place.
Totally agree. I think with the virtual care wards, there's obviously the opportunity to save costs on electricity and beds and those sort of factors, but actually you still need high quality sort of nurses and doctors to deliver it, and that's what's at the premium, isn't it?
And we may need to, grow that workforce. And I think we will need the types of roles that we have already got. I think we will probably need to redesign some existing roles and ways of working, and we may need to bring in some new roles to support virtual care, because for me, I very much look at the world through outcomes. What are the outcomes that we need to achieve? And once we know what those outcomes are, then within our workforce, how do we configure it and who do we need to best meet those outcomes? I know we tend to see healthcare workforce a lot of the times through numbers of doctors and nurses. And as a former nurse myself, I'm very passionate about my profession and what it does and the unique characteristics nursing has and the absolute benefit and value add we bring to patient care. But equally, I'm humble enough to recognise that some of the things I may have done traditionally could be done very safely, very effectively by somebody else. And I think we just have to, again, our starting point is, what does the patient, what does the population, the community actually need, and we start building the house of our workforce planning and our workforce development from there.
And as an organisation, we're actually doing some work on that space, aren't we, with a framework?
Absolutely. So we've recently been commissioned by NHS England and Improvement to develop a core capabilities framework that's going to be looking at virtual care wards and urgent care. And we're starting with a core capabilities framework in large part to support what I've just said a few moments ago, that we need to identify the skills, the competencies, the capabilities that are required, and I would say required quite immediately, to upskill staff for these services, but to actually take a step back and look at what are the skills and competencies that are required. And some of those things will be more generic in nature, others will be very specific, particularly to urgent care or to virtual wards. Some of those skills and capabilities we identify will be those that we can easily attribute to existing roles, but it may then lead on to the identification of new roles and ways of working. But what we're doing is we're putting the needs of the patient first and making sure that we identify those capabilities that are required to have a safe, highly skilled workforce in place that hopefully should placate some of the concerns people have around patient safety. So the work is just beginning. We've formed an expert reference group to help pull the framework together. Myself and a few of my colleagues will be working on that to facilitate that process. And then later on in the year, we will have a draft framework that we will be going out for wider consultation on. And that's going to be a really important part of the development of the framework. It's an important stage because we'd love to have 200 people around a desk, but that's just not going to happen. So we're working with a small group of stakeholders who are experts in the field, but we really want to gather and have the input and the expertise of a much wider group of stakeholders. So we have set up a project webpage where people can register their interest, and when the framework is ready to go out to consultation, people can be notified and they will then be invited. It will be an online survey with some key questions, and we will spend a considerable amount of time looking at people's feedback, looking at people's insights to then craft a really high quality product that can be used to support a whole host of workforce development interventions.
Fantastic. Brilliant. So, one of the news stories that caught your attention over the last week or so was the reported drop in MMR vaccinations to below 90%. Obviously, this is a concerning development. Can you explain what this news means in terms of levels of protection and immunity?
Kind of the golden number for MMR uptake is, the population have had 2 doses should be over 90%. And I think off the top of my head, ideally above 93%. And I came across some news the other day that the uptake of MMR for people who've had 2 doses has actually now fallen to a UK average of about 86%. And that is a particular concern for measles. I mean, all measles, mumps, and rubella are all worrying illnesses and viruses, but particular measles, which is incredibly infectious, that whilst there isn't a measles outbreak pending, if the levels of immunity, is below, stays around that 86% level, we do run the risk of having a measles outbreak at some point in the near future. So it's kind of measles, mumps, rubella. During the last 2 years, all we've thought about and talked about is COVID. That's been the virus that's been on the front news page. Obviously, the COVID vaccine has been the vaccine that everybody's talked about, but the old viruses haven't gone away, and the need to have immunization for those traditional viruses, if I can call them that, hasn't gone. And it just made me think, yes, we really need to double our efforts to improve the uptake levels.
Can you put your finger on why the uptake has fallen?
Well, as you know, MMR has had a rocky road. For those of us who can remember the challenges from nearly 20 years ago with the link to MMR and autism in children, which I have to say was completely, utterly debunked. So, but I still think there's still in a lot of people's minds that's still there. So I think it's never gone away completely, which is why I think we always have to keep banging the drum about MMR is safe. It's really important that people have it. And I think whilst we've been so focused on COVID, maybe some of our public health messages haven't been as, we haven't had an MMR campaign, and maybe we need to think about doing something like that. Equally, staff have been tasked solely working in COVID, providing COVID care, giving COVID immunisations. When I went for my booster dose, I was immunised by a midwife who had been moved away from her duties providing midwifery care to running COVID clinics. So we've been focused on COVID. I'm not saying we haven't been immunising, of course we have. It's not been as clear in our thoughts as it perhaps was in a non-COVID world. Also, we've had a couple of years where children have been in and out of schools, nurseries have been shut. So children haven't been in the places where they perhaps normally would have been. And because we've all been thinking about our COVID jabs, when the reminder comes through about, a booster for things like MMR, it's perhaps fallen down the priority pecking order. I think because we've seen so much illness and death with COVID, because the MMR is so successful, we actually see very few cases of the serious implications of things like measles. But let me be clear, measles is a killer. If you don't have the measles vaccine, don't just think, oh, well, it'll be okay because my child will only have a mild dose of it. They very hopefully will just have a mild dose of it, but there are significant risks to, those things like measles, mumps, rubella, and I really would encourage people to, if their children are due their MMR, to take it, and that we think about, the colleagues we've got listening to this who are members of the workforce, that we perhaps need to think about how we promote the uptake of the vaccine in the work that we do. Very often it's that brief intervention. A patient may come to see you about a completely unrelated matter, but it's just that gentle reminder, we think such and such is due for a vaccine, and just planting that thought seed can be a really powerful tool.
Mm. Yeah, I've just been looking at some of the stats, and you're absolutely right about the immunisation, and it's for deaths of about 120,000. Previously, they were in the millions. It's a very, very successful vaccine.
Yes, and sometimes then it can become a victim of its own success because, my parents are well into their 70s now, and they remember a world where we didn't have immunisations, and a school friend of my mum didn't die but was very, very ill from measles. My other half has an uncle who had polio as a child and has spent his entire life walking with mobility aids. You prevent things happening by keeping on top of things. So MMR's been in the news, but I think all those traditional immunisations that we've had, they perhaps need to have a bit of airtime, and we've been doing that today because it's really important that people do take up those immunisation opportunities.
Yeah, like you said, it's probably just been difficult cutting through all the COVID noise, hasn't it? And
Absolutely.
like you said, hopefully this will have its own platform going forward. So, final news story to sort of get your thoughts on. It's about the sort of like the rising cost of living. Inflation's increasing, not just in the UK, but doubling in the US as well. And perhaps how this might impact the direct impact on those working in the healthcare in terms of people being able to heat their homes and eat properly, and just perhaps what your thoughts were about this particular trend that we're experiencing at the moment.
Absolutely. I mean, as a former public health practitioner, I'm very aware that the things that impact on your health are just as important as the quality of the healthcare service that you receive. And an old expression, you can't have health without wealth. And I'm concerned that as people are experiencing the cost of living squeeze, and I'm not going to go into the reasons why we've got a cost of living squeeze, I'll save that for other podcasters. But what does concern me is if you can't afford to heat your home properly, if you can't afford to eat properly. I remember an awful expression I heard, do you heat versus eat? That is going to have an impact on your physiological and your psychological well-being at all ages of the lifespan, and an impact on your overall health and well-being outcomes. I never knew what it was to go to school and be hungry. I went to school with a full belly, but I imagine if I went to school with an empty belly, would I be able to learn as well as I did? Would I be able to sit and pay attention where all I can feel are the gripes in my stomach? If I'm not learning, then I'm falling behind. If I fall behind, my later life outcomes are going to be diminished. If I suffer from a long-term condition such as arthritis, living in a cold house that I can't afford to put the heating on, that's going to exacerbate my underlying condition, but it's also going to affect my ability to engage and have a well-meaning, productive life. So I think when we talk about health, very often we talk about health care and what we do as healthcare professionals, but it's people's lived experience and their life chances that are just as important to their overall well-being. And I really think we're going to have to think about how we, as healthcare professionals, meet some of those challenges as much as we're able to, as well as being focused on treatment. We have a national health service, not a national treatment service. For me, public health, looking at health and well-being, looking at the needs of people, to use that expression, further upstream, is going to be really important. If we don't look at it, it will come to bite us later on when people do land in hospital with exacerbation of underlying health conditions, when, because of poor choices made earlier on in life, their health status is diminished. So health prevention, health promotion, health and well-being, for me, are not the nice to do's around the peripheral. We absolutely need to focus and really start from how what we do adds value to people, individuals, populations, groups of people, however you want to, whatever expression you want to use. How do we tailor what we do to best meet their needs?
Mm. You're just worried that it's just perhaps like another wave coming crashing towards the NHS, and be not interesting, but enlightening to understand if there's going to be an increase in cases of malnutrition or pneumonia or.
So I remember many years ago, a local NHS organisation really scaled back on its level of NHS podiatry because they argued they were under incredibly financial challenging times, and said a lot of what we do in terms of nail care was not really it wasn't a health need, it was a social care need, and we can't afford to provide that anymore. So I'm very sorry, Mr. Smith, but we won't be able to provide that foot and nail care to you anymore. And services were reconfigured, cost improvements realised. That service then focused on higher risk individuals to provide them with a better quality of care. But then you imagine, if you can't cut your toenails, how is that going to affect your mobility? So you either don't go out, or you go out and you're in incredible pain, or it affects your mobility to such a degree you're at a greater risk of falls and injury. And the cost of a fractured neck of femur and the repair, to basically repair that, and the mortality rates from such an injury, so the cost to somebody's life, for me, is always dwarfed the cost of providing a nail care service. So, that's a good example of making a decision today where, okay, we release a benefit right here and now, but are we just storing up problems for later down the line that are going to cost us twice as much? I have an expression, which I have lots of, that the listeners are probably gathering now. Not sure, Dom, if you've ever heard this. I call it the M5 syndrome.
No.
So the motorway that runs from Birmingham down to the southwest, large parts of it, when it was originally built, was only built as a 2-lane dual carriageway because central government insisted that was all that was needed, because they'd done traffic flow projections, and by only making it 2 lanes, they'd save a fortune that could be spent elsewhere. Well, what happened? After a very short number of years, the motorway was congested where it was 2 lanes only, and they had to widen it, and it cost them 10 times as much to widen it. So that kind of, penny wise, pound foolish, those short-term savings have a habit of coming back to bite us on the you-know-what.
So thank you for listening to this special News Edition podcast. We'll be back again soon with another edition of Lovegrove on Health. Don't forget to subscribe wherever you get your podcasts from, or visit the Skills for Health websites. Many thanks.
Bye.